My name is Dr. Harsh, and I am a second year rheumatology resident at Army Hospital, Delhi. I will be presenting an interesting case of infection in a case of idiopathic inflammatory myositis we had come across. So we had a 34-year-old male who was a soldier by occupation and a resident of Rajasthan, informant being self. He had complaints of polyarthralgia, which was predominantly in the larger joints with early morning stiffness and intermittent and low-grade fever, and had this presentation in the month of May 2021 and had no other complaints. So his investigations had shown elevated acute phase reactants, and his ANA by IF, RF, anti-CCP antibodies were negative. RF was low titer positive. So he was initiated on methotrexate, HCQS, and low dose prednisolone, and had a good response over a period of 12 weeks. For which and followed by which he had stopped his medications, and he remained asymptomatic from September 2021 to December 2020. In December 2021, patient again developed low grade intermittent fever, but this time he had a slowly progressive painful swelling over his right calf. His investigations had revealed anemia and mild leukocytosis, and USG had shown intramuscular hematoma of around 8.3 to 4.7 centimeters. However, the fever was not explained if there was an intramuscular hematoma. So he underwent with medial fasciotomy, which had revealed a pus pocket, and 20 cc of pus was drained, and the necrotic tissue was debrided. The pus was negative for gram, Zn stain, and fungal stains, and the patient was managed with antibiotics followed by wound closure and was afebrile and symptomatically better till February 2022. In February 2022, the patient presented to our center with high-grade fever with chills which were daily, and he had proximal muscle weakness which was progressive, and he also gave history of weight loss of over 9 kg over a period of 4 months. So his muscle weakness had progressed initially involving proximal muscle weakness in the limbs, followed by trunk and neck flexor weakness. He had no other history of any other connective tissue symptoms. On examination, his vitals were stable, and he was having proximal muscle weakness and neck flexor weakness too. So this was the image of the wound, which was healing properly after the fasciotomy procedure. His investigations had shown anemia of chronic disease, leukocytosis, elevated acute phase reactants, and his CPK levels, LDH levels, and AST/ALT were elevated. However, urine blood cultures were negative, and his NFC had shown dilated nail fold capillaries. So we were suspecting that the patient was having dermatomyositis. However, he didn't have any skin involvement at this time. So MRI thighs had revealed hyperintensities in all the compartments of the thighs, and his immunological investigations were positive for anti-Rho60 and Rho52 autoantibodies. However, his complements were normal, and IgG was quite elevated. However, he didn't have any myositis spectrum or a myositis specific autoantibody. So we went ahead with IVIG. We were also suspecting for any evidence of infection. However, we didn't find any, and PET-CT had revealed no evidence of malignancy. And his fever had responded to IVIG in the month of February 2022. However, his disease course was complicated by recurrent episodes of syncope with bradycardia, and his ECG had revealed complete heart block. We went ahead with 2D echo, and 2D echo had showed ejection fraction of 45% with no regional wall motion abnormality, and coronary angiography was normal. So, and even the cardiac MRI was unremarkable. Because of this complete heart block, we went ahead with permanent for temporary followed by permanent pacemaker implantation on 2nd March 2022. As we were suspecting that this patient might have myocarditis with CHB, complete heart block, we went ahead with pulse methylprednisolone, and we saw a dramatic response over a period of 4 weeks. That patient's ejection fraction had increased, and MMT scores had also increased. So patient was discharged on methotrexate and oral prednisolone. Again, in April 2022, patient had recurrence of fever, but this time this was high grade and had pain and swelling with discharge from the right calf. So on examination, his power was normal. However, we saw multiple discharging sinuses from the right leg. We had sent the sample for cultures by the time we got his MRI right leg. And here we can see that in the right gastrocnemius head, there is around 100 cc of collection was present. and pus had come positive for the AFB, and we had diagnosed him as a case of TB pyomyositis. And we had started the patient on 4-drug ATT, and fever had responded to pus drainage and ATT. However, after the completing intensive phase of ATT, patient had recurrence of high-grade fever and was complicated by persistent discharging sinuses. And so we suspected that after completing 8 weeks of ATT, he might be having a paradoxical reaction, to which we started 50 milligram of oral prednisolone. However, the frequency of fever reduced. However, he developed a new discharging sinus over the right heel, and the pus was showing high AFB load. So now we had almost reached dead end, as we were already treating tuberculosis, and we already gave him prednisolone for iris, and patient was having normal power. So his myositis was in remission at that time. However, infection was not being controlled. So we did a search on review of literature, and we tried to give him local streptomycin injections near the discharging sinuses. They were administered because ATT drugs have shown poor penetration in acidic medium. And there was already new discharging sinuses were being formed. Patient had a high TB load and was already immunosuppressed because of previous prednisolone pulse and high-dose oral steroids. So we saw a dramatic response in the healing of this discharging sinuses, and over a period of 2 months, he had the sinuses were completely healed. So I would like to summarize my case. A 34-year-old male who was initially treated as inflammatory arthritis with the remission for a period of 3 months, followed by which he developed right cuff swelling and fever, which was managed with medial fasciotomy and antibiotics. However, in February 2022, patient presented to us with myositis and responded to IVIG, followed by complication of myocarditis and complete heart block, requiring prednisolone and pacemaker insertion, to which he responded. And in April, his disease was complicated by TB pyomyositis and iris, to which he responded with the help of ATT, streptomycin, and prednisolone. And by the month of September, he was asymptomatic and was on HRE and February 5 milligram prednisolone, and he completed his ATT on 29th of Jan 2023. However, this time in April 2023, he had a recurrence of myositis, and this time he had Gotton's rash. He was initiated on methotrexate and was in remission, and TB has not recurred yet. To discuss a review of literature, I will be focusing on heart block incidence in myositis, the role of Rho52 and Rho60 antibody in heart block, and incidence of TB pyomyositis in IIM. So conduction abnormalities have been seen in around approximately 32% of the patients, and most commonly they have left anterior hemi block and right bundle branch block, and the incidence is around 13% and 9% respectively. And these patients may lead to congestive heart failure. And in this review, around 619 patients were reviewed, and 5 of them had complete heart block and they required pacemaker. In this case report, 59-year-old female who had dermatomyositis with Rho52 positivity had succumbed to congestive heart failure. Post-mortem analysis had shown that patient was having focal areas of myocarditis and segmental necrosis with fibrosis of the conduction system. This study had shown that patients who were having anti-mitochondrial antibodies were having a frequent association with cardiac involvement. However, these patients were also having Rho52 antibodies along with them. This was a review of 5 patients who were having dermatomyositis and had presented to the clinic with thigh swelling and were diagnosed to have tuberculosis, but all these patients were having pulmonary tuberculosis. And in this case report, one patient had no evidence of pulmonary tuberculosis and was taking 15 milligram prednisolone for dermatomyositis, and after completing 8 weeks of ATT had developed a paradoxical reaction similar to our case and had required local puncture, drainage, resection, as well as local streptomycin injections. So these were the images of the patient who had presented with thigh swelling. Thigh swelling is a common presentation for tuberculous cold abscesses. However, our patient had presented with calf swelling and he had no pulmonary tuberculosis. So key messages were that we wanted to bring a notice about that we should screen for cardiac involvement in all patients who are having myositis, especially when anti-Rho antibody is present, we should aggressively manage these local musculoskeletal swellings because they might have underlying tuberculosis. And we wanted to highlight the use of local streptomycin injection in difficult to treat tuberculous cold abscesses.